a summer school day dedicated to the concept and to the theme of mindfulness-based cognitive therapy is really wonderful. And the ability to examine the different strata of the approach from the historical perspective that Mark gave, the broad spectrum possibilities and potentialities that John spoke about, and then what I'm going to talk about today, which has a little bit to do with, I guess, a more mundane but very highly pragmatic focus of MBCT in the world. And I've labeled my talk Promises and Pitfalls of Increasing MBCT's Public Health Significance, but I could just as easily have labeled my talk Meanwhile the World Goes On, which some of you may recognize as a line from a Mary Oliver poem. And the notion of meanwhile is that as we are concerned and focusing our efforts with mindfulness-based cognitive therapy, as we've come to know it through the Green Book, through the work that we've done, through the workbooks and the Mindful Way Through Depression, the world has evolved around us so that those may almost seem like archival methods of delivering the same content. And there may be important drivers of finding ways to make mindfulness-based cognitive therapy a little bit more accessible. I'd like to talk a little bit about what the rationale for that might be, what some of the safeguards and some of the risks are to the integrity of this program, and then to describe one of the efforts that we've tried to make manifest to allow this to happen. We'll have a chance to do a little bit of practice in the middle of my talk so that we can use that experiential sense of the practice as a potential yardstick to see how much or how little of that is possible to achieve in some measure of saturation as we migrate from the concept of in-person MBCT groups to MBCT being delivered on the web. So just to revisit some of the historical context that Mark had spoken about. When John and Mark and I were meeting, there was a zeitgeist at the time for treatment efficacy of depression to be carefully researched. And this was backed up with funding from agencies such as the National Institute in Mental Health. And there was almost like a racehorse or a one versus the other mentality to see whether effective treatments for depression could be discovered. And this was a study that came out, initially the original publication was 1989, and these are follow-up data that were published 3 years later, comparing imipramine, interpersonal psychotherapy, cognitive therapy, and placebo for the treatment of depression. This was a study funded by the NIMH to the tune of about $10 million in 1989, which was the largest psychotherapy trial ever funded. And at that time, the arguments really weren't so much between cognitive therapy and interpersonal therapy. The arguments really were between antidepressant medication for a disorder that was characterized as a biological disease process versus the possibility that anything in the realm of talk therapies could have an impact. And the New York Times headline, when the initial study was published, trumpeted the fact that psychotherapies for depression performed on par with antidepressants. And so that was the big takeaway. It was also an opening at the time for psychotherapies to have increasing legitimacy on par with what was considered to be a disorder that would only respond to antidepressant treatment and all the interest in biological interventions. So out of that framework and out of that time, interpersonal psychotherapy was developed, and interpersonal maintenance psychotherapy was developed. Cognitive therapy, did very well on its own, and then there was this interest in developing a maintenance version of cognitive therapy, and I think Mark told you the trajectory of where that went. But as Mark also indicated, the focus on efficacy seemed to be a bit of a mismatch with the needs of patients who were experiencing depression, not just in terms of the impact of the disorder, in terms of symptom burden, but in the other realms in which depression related and produced increased disability. Family disruption, absenteeism, even studies showing that patients who had suffered a couple of episodes of depression would have a lower median income over their lifetimes compared to people who were working in the same jobs but didn't have that history of mood disorder. And so increasingly funding agencies, and I think the general public, started to recognize that we're dealing with something here that has the scale of a mental health epidemic, or a crisis that's much more larger in scope than potentially individualized treatments, one patient, one therapist, one remission could potentially achieve. And there has now been a push to step away from efficacy, almost as if the thinking is we've invested many, many millions of dollars and many years of study in efficacy, and we know a lot. We may not know everything, but we know enough. That the challenge is now rolling out what we know to the people in greatest need, and not waiting further for perfection or refinement of models based on small parameter changes. That the real challenge now is to consider from a public health perspective how depression can be addressed. And so this shift from efficacy to public health, I think, has caught some of us unawares. I was raised, as were many of my contemporaries, as clinical trial efficacy researchers, comparing one treatment against another, using standards of randomized clinical trials that were considered to be state-of-the-art, to reduce bias, to increase interpretability of studies. And guess what? There's very little interest in funding those studies right now in the area of depression. Funding agencies, at least in North America, have very little appetite. And I think part of that comes from monies that have been spent, the large STAR-D study that looked at what happens if you sequence 4 different types of antidepressants to people who don't show an optimal response to a first-line treatment or cognitive therapy, with essentially the results being a little bit of a muddled outcome of there's not much gain in adding medications. You may get an additional 10 to 15% benefit, but there's still a lot of information that gets lost, patients who do not respond. And so those monies are now being shifted towards moving strategies into the public sphere. And some of the ways of doing that are different from how we were taught to be helpful in the context of depression. So for example, mental illness prevention, mental health promotion, treatment, recovery, and rehabilitation. Some of these are very important examples. And if you look at some of the public health interventions that we've all participated in, for example, in Toronto, after the SARS outbreak and contamination, all of a sudden you would see these hand sanitizers appearing everywhere, buildings, washrooms. Even when I use the washroom here, the Dyson hand air cleaner is considered a less contaminant form of drying your hands than pulling out Kleenex from a dispenser, fluoride in water, vaccinations for children. These are mass-based interventions that have an impact, even though each intervention itself may be considered to be relatively low intensity. So public health moves the needle from an individualistic perspective to an approach that has a wide-scale, broad-spectrum potential for solutions, or solutions that are well mapped onto a broad-spectrum approach. It shifts the focus from responding to the person to protecting or to looking after the needs of the community, and it emphasizes early assessment and intervention, possibly in people who are not yet symptomatic. And so some of the more blatant and potentially effective ways are through messaging and message framing that allow attitudes and biases that prevent treatment access from being exposed and addressed. And so because I'm presenting here, I thought some of the royal family being advocates for mental health would be a nice thing to see. But billboards purchased by the Massachusetts Bureau of Mental Health, talking about good mental health, starting with the conversation, some of the ways in which mental health issues can be masked by people feeling that they would be exposed or shamed in addressing them, and some of the other attitudes about mental health issues being invisible, so therefore they're not as legitimate as, say, physical problems. So public prevention and awareness is one part of it. And the other part of it is how well do our treatments match onto these strategies so that we can consider them as being an arrow in the quiver of a public health strategy. And so Sona Demijian and I reviewed all of the research for mindfulness-based cognitive therapy and mindfulness-based stress reduction and tagged it according to this treatment development stage model. I know it's a lot to take in, and I'll try to walk you through it. So the treatment development stage model maps the trajectory of a treatment from the point at which it's developed, say, as in the case with cognitive therapy for panic disorder. Let's say there's some basic research that suggests patients who have panic disorder have catastrophic misinterpretation of bodily sensations. That's the core finding. Hey, let's see if we can build a treatment around it. Hey, let's see what happens when we take a treatment built around that core finding and evaluate it in an open trial, or we evaluate it in a randomized controlled trial, and then we evaluate it in the community, and then we can find a way of rolling it out so that it can be available maybe in a way that doesn't fully resemble what it looked like initially, but lots of people can get access to it. And so what you see here is the saturation of color representing the stages of this model and how far into this cycle mindfulness-based therapies have progressed. And the answer is that they've actually progressed not very far from the point of evaluating the treatments and developing the models, so that most of the work, and you can see this is going to be the dark blue square and those two lightly colored blue squares, but then as you start to get into the third stage, what are the efficacy of these treatments in community clinics? What is the effectiveness of just offering them in a very low intensity way to large numbers of people? What kind of implementation and dissemination have mindfulness-based interventions been able to achieve? There's practically nothing there. And so from a public health perspective, this is exactly where you need to go to. And there's two reasons for this. The first reason is something called voltage drop. And this is known as the phenomenon where if you take, and MBCT might be a wonderful example of this, if you take the studies of MBCT conducted in academic research centers or hospitals, the first studies, and you compare them to studies that might be involved in a much broader scale dissemination, maybe with therapists that aren't as well trained, maybe with resources that involve potentially a book or a video or something like that, but you're able to reach many, many people, chances are the efficacy or the effect size of those treatments is going to be smaller than the ones that are based on effect sizes from initial studies. And you see this a lot in not only in psychotherapy, but in the way in which, for example, paramedics perform specific procedures on their training courses as opposed to doing it in the field in the middle of the night on a Tuesday. But if the voltage drop isn't too great, the therapies can still have some success. The other part of the public health trajectory that's important to know about is something called the implementation cliff, where therapies are developed by researchers, people that have the background and interest in formulating these interventions. But there's very little communication with how those interventions can get embedded in health systems that can deliver them. And without implementation, these things sit on a shelf in a researcher or professor in their office, and they actually never move beyond the initial publication. And this is the same for websites, that if you look at some of the websites that are currently available for cognitive therapy, say, they are hosted by organizations that are willing to take on the cost of back-end security, IT, hosting costs, dealing with all of that in order to make the websites available. So implementation and voltage drops are barriers to the dissemination of finely, beautifully produced treatments like MBCT. We are no different in that regard, and we need to try to engage with them to see how we can increase the public health impact of our work. So one of the ways of trying to address that is to go to the web. as a number of CBT treatments have done, because the web, internet-based treatments reduce a number of barriers to access. They reduce barriers that have to do with finding qualified therapists in jurisdictions where none may exist. It's funny to me that in the US, in a city like New York, where practically everyone is in therapy, it's really hard to find more than 2 people that I can refer to, that I know of, who run MBCT groups. It may not be the dominant flavor of therapy there, but there are not that many people who just run groups, use the protocol, and operate on that in that way. And so it's harder if you're living in Milwaukee or St. Louis to find an MBCT therapist, if the only way of accessing that is to go and sit in on an 8-week group in person. There are also barriers related to timing and perhaps being able to do it on your own at home in a self-guided way, on your own schedule, is also another barrier that can be removed by providing information online. And the other piece about providing information online, treatments online, is that the fidelity of what you're getting is always guaranteed to be at a high level. It doesn't change based on whether your therapist graduated from here or had lots of training or wasn't really supervised. So those are some of the advantages. And I think that we've seen that there are more and more problems that are now being potentially addressed through the lens of online treatments. This is just a listing of some of the more prominent ones, including Fear Fighter for Panic, Beating the Blues for Depression, Good Days Ahead for Depression, a more well-being oriented website, Health Media Solutions. There's also Sleepio and other custom designed online treatments. So it's no longer something which is provocative or extreme to suggest that people can go online, use their computer to access high quality care. And some of the studies, if you fully believe them, I'm not sure that I do yet, suggest that online treatment can be on par with what people would receive at the hands of seeing someone in primary care. So the data are significant nonetheless. Now, some of the things that are, I think, important to say when it comes to online therapies is that the effect sizes of these treatments increase with the amount of human contact that is provided. So some of the ways in which online therapies are seen as being beneficial is that it's also not very expensive for a health system or for a specific jurisdiction to offer treatments to multiple people if the costs are fairly moderate, but you can have a website that is only offered in terms of its online content. What is on the website is what people can benefit from, but there are also ways in which the website itself can be supplemented by a phone call from a coach. It can also be supplemented by a text message on a regular basis or a phone call from a therapist who is then tracking your progress through the website available to talk about issues that come up. And finally, that therapy itself can be supplemented by referring people to websites. If, for example, as is often the case in the US, you may have an insurance policy that covers you for 8 or 10 sessions of therapy, which may not be enough. That could be supplemented by referring you to an online treatment where you can continue to do some of the work. So those are some of the important moderators, and of course, as we add human contact, we add cost. So the cheapest version of this type of intervention is just doing the online program itself. It costs very, very little to have a website that can be available to thousands of people around the world. Very little. But then if you add a phone component, coaching component, if you add a therapist who is doing text messaging to help people stay engaged, or even if you're adding it to therapy, then one of the rationales, anyways, for the online treatments starts, I think, to melt away a little bit. And it all depends on what the sweet spot is with respect to cost and affordability. So those are just some of the general themes, but we're not talking about necessarily providing cognitive therapy or interpersonal therapy. We're talking about providing mindfulness-based interventions that have their own peculiarities, both in the delivery and in the teaching, and also in the assurance that the patient experience can have some of the formats of what John was talking about to enable this shift in supermodel or mental models that come through practice and through engagement. So when we encounter this, we encounter the potential discrepancy between traditional modes of teaching mindfulness to teaching mindfulness via the web. And traditional modes of teaching mindfulness, which have been around for a very long time, and part of my reluctance to mess with this by seeing if it could be migrated to the web, was wondering whether there would be a kind of corruption of long-standing wisdom and guidance around how mindfulness can be taught, communicated, and catalyzed in someone else. So some of the generic elements, I guess, in traditional modes of teaching mindfulness emphasize the fact that often this learning occurs in a dyadic relational frame, that often the learning is experiential, that often there is content that does get communicated, that the learning is often self-guided, where you may have a meeting with a teacher and then you go off and maybe come back in another week or a certain space of time, and you're taking yourself through what your practice is in the way that it unfolds. The experience is immersive, that it is something that often involves a dedication, and it can't just be kind of plucked when you have a little bit of free time for it. You need to create space in your life for this type of learning. And also that there are often groups, communities, or sanghas that help to facilitate this by providing the perspectives of common movement or struggle by other people on a similar path. And so the web is good for some of these elements, but it may not be ideal for all of the elements. The thing that the web is good for is delivering content. And if you look at the 8-week program in the second edition, there's a lot of content there that we do emphasize to help people understand the depression nature of mind, the way in which thoughts and certain configurations can come up and become quite familiar and potentially recognized. Web-based interventions allow a high degree of self-guidance. People can basically log on to the website whenever they have a free hour, and as opposed to having to come to a hospital appointment, it can be flexible with their schedule. And anyone who's played video games for long amounts of time or has children who does can vouch for the fact that web content can be very immersive, hours on end. I can vouch for that personally. So what have some of the solutions been that have tried to do this type of blending of traditional elements in a web-based delivery format? What's that looked like? Well, one of the websites, which is the Headspace website, tries to do this in a very generic way for training meditation or training mindfulness, and has information about the kind of techniques or details of practice, along with guided practices that people can download. They are customized, they are briefer, sometimes they address specific topics, and then there's a way of staying hooked into their program because they send you notifications, ask you how you're doing, and that becomes your hub, if you will, for learning this on the web. So the main experiential piece is you get to practice audio-guided meditations, and then there's a holding piece where there may be some questioning back and forth, but it's really providing that to you on the web with some description and some content of what you might be expecting. Another web capacity is for synchronous video conferencing tools that allow an MBCT group to be held with people all over a country, joining at the same time, being guided by a teacher. So that is the teacher in the sort of middle left quadrant. There is a commentary field at the bottom where people can type questions. And there's also in the middle right edge quadrant, you see the people who are commenting, so that there's a sense too of being involved and who the people are that are speaking and what the interaction is like. And so in this way, this is the closest thing you can come to attending an MBCT group without having to leave your house. And there are companies like eMindful and others that offer this to organizations such as insurance companies who allow their employees to uptake this, and that also guarantee a certain level of anonymity so that employees don't have to self-disclose that perhaps they're dealing with a depressive or an anxiety problem or that they have stress in their lives. They can just do this. The company gets the benefits of the exposure to this, and the employee has a chance to do something that I think is probably very convenient. And then there's the Be Mindful online course, which is a pioneer, I think, in trying to move this to the web in a meaningful way. And the Be Mindful online course is essentially as many of you might know, watching two teachers take you through each of the sessions, and you have the capacity to watch their guidance and their questioning and their format of the content in a way as if you were at a session. And then through that, there's a way in which you're encouraged to practice. So I think it's a little bit more full bore than, let's say, Headspace. It's also more narrowcast to MBSR, to an MBSR MBCT hybrid. And it is also people coming a lot closer. It's asynchronous, so they can do it in their own time. And so these were the formats, I guess, that were available, that continue to be available, and that offer some response to the question of how can this migration work with high integrity. And our foray into this area occurred when we were able to receive funding from NIMH to develop a version of MBCT that could be digitized and available to patients who had residual depressive symptoms. And we did that in one trial with 100 patients who were treated in Denver at Kaiser Permanente Health Maintenance Organization with an open trial to see how that went. We consulted with a number of people, including Mark and John and others, about content and how to do this and how to do that. And now that website, which we'll have a chance to look at briefly, is part of a larger study with 460 patients at the same site that are being compared to a cohort who is essentially receiving treatment as usual for residual depressive symptoms, or treatment as usual plus getting access to the 8-week online program. So the goals are fairly modest to see whether people with residual symptoms, often the people who are actually neglected in these health maintenance organizations because their symptoms are not at a level where they are going to be high enough to warrant retreatment, but they're not entirely gone, so that they're still at risk if they flare up again of potentially moving back into an episode or having a relapse or recurrence. And of course, the question is, what is the learning engine in MBCT delivered online? Where are the decisions that we made, that we took to try to put the emphasis and potentially maximize the chance that people can learn importantly, experientially, much in the way that happens in an MBCT in-person group? So in our work, we identified these 4 elements of MBCT that we would want to see replicated through an online delivery platform: practice, inquiry, the teaching points of each session, and some of the group input. And so our learning engine has as a basic principle the capacity for people who are engaging with our website to cycle through each mindfulness practice through 3 different modes, learning potentially about the practice itself through these different perspectives. And as we'll have a chance to see, one mode is that people are first led through the practice. So audio guiding, they log on, there's some orienting information, and then they listen to audio guidance and practice. The second mode is that they are given text fields to reflect on their noticings of what came up. So they write in response to some questions. The third thing, and the third way that they cycle through the same practice, is by watching edited video clips of a group that Sona Demidzian, who is a collaborator of mine, and I ran, that are edited to address issues related to inquiry and some of the common questions that come up from that very practice. And they do that for each of the practices. So it's not a one-off for the practice, but the practice itself is then cycled through from a kind of conceptual reflective, what did you notice? And then from this group input around inquiry. And that was really our best shot at how we could try to saturate this digital platform with what we felt were the important elements of MBCT. Now, in terms of just general parameters, the engagement with MBCT online, which is called Mindful Mood Balance, was pretty good, especially for online programs which have a tendency to be a novelty initially and then relatively quickly forgotten about. So if you look at a lot of websites, people go through the first 2 or 3 pages, but if it starts to get hard work or they are being asked to do this or do that, then often they don't come back. And we were able to get 42% of our patients completed all of the 8 sessions, and 52 completed at least 4 sessions. And mean frequency of formal practice was about 2.5 times per week. And more informal practices like the breathing space was about 8 to 9 times per week, which is, I think, pretty good for a website. And for people needing to be incentivized through what is available to them through the website and their own either belief or conviction that this might be beneficial. And the first results that we published showed that there was this decrease among people with residual depressive symptoms as a result of completing the MMB program. So a small decrease, but we were looking at people who were within a range of 5 to 9 on the PHQ-9. These were the residual depressive symptom folks, not completely in remission, but not fully in episode. And then when we compared them to another group of patients, this was a quasi-experimental control group of people, another 100 people in the healthcare system there who had just gone through the usual care, but we used proximity matching to ensure that they were equivalent on about 12 or 13 parameters like age, gender, socioeconomic status, et cetera, a fairly well-matched group. We see that there is a decrease for MMB, but not for the folks in usual care. So what I'd like to do is to have us actually take a look at the program itself. But before we do that, what I'd like us to try to do together is to practice a 3-minute breathing space and use that as a foundation for your own self-knowing of what it is that we're trying to see about putting on the web. And just if you just stop and listen, what you'll hear is the rustle of people's bodies changing posture, moving into a posture for perhaps sitting and practicing. And so giving yourself the time to do that, to shift into a way of sitting that allows you to feel supported, comfortable, present. And if you feel comfortable, also allowing your eyes to close, or just, if you prefer, leaving them open and finding a spot 4 or 5 feet in front of you and holding that with a soft gaze. And taking a moment to tune into the sensations of sitting. The soles of the feet pressing into the floor, the chair supporting the weight of your body, the spine, the neck, the head in alignment. And then when you're ready, perhaps bringing your attention and looking into the mind, asking yourself, what is my experience right now? What thoughts are present? What feelings are here? What bodily sensations are making themselves known? And as best you can, allowing all of these elements to be present, watching them, holding them, not needing to change or alter them in any way. Simply being with them as best you can. And now, if you're willing, seeing if you can let go of the contents of the mind and bringing your attention to a single pointed focus on the breath at the belly or wherever in your body the breath makes itself vividly known to you. And feeling the rising on the in-breath, the falling on the out-breath, the sensations of breathing, one moment to the next. Breathing in, breathing out as best you can. And now, if you're willing, seeing if you can expand the focus of awareness around the breath, allowing your attention to radiate outwards into the whole body sitting, the whole body breathing. Feeling the body from the soles of your feet to the crown of your head. And if you're willing, seeing whether you can expand your attention even further to the skin and the air, caressing the skin, and even into the room itself, the space around you, holding all of this as best you can in a wider and more spacious awareness. And then when you're ready, just allowing your eyes to open. So I think I'll stop here. I hope this has been an animated and interactive session. I really appreciate the chance to come here and talk to you about this, and thanks very much for your attention.